Now we will move into the last item of the agenda, which is very important, and we're going to do our best to get through what we have here. We do have a resolution proposed also, and it relates to the budget process, so we want to get through. But I will turn it over to, first of all, I know we have several people signed up to speak on this, and I'm going to leave it up to Commissioner Harris. I'm showing 4, possibly as many as 6 people signed up. So I'll leave it up to him as to whether he wants the people to speak first or whether you want to go into the presentation and then have them speak.
I think I'd rather have the presentations first.
Okay. Yeah. I'll turn it over to Chris, though, to introduce the item, and then we'll go with the presentation.
Thank you, Chairman. So back in 2017 of last year, the city auditor released a report as it related to APD response to mental health crisis. That same month, the city council included in the budget for FY19 money for a study conducted by Meadows about our first response system as it relates to mental health issues and people in mental health crisis in our community. Both of these documents found a lot of opportunities for improvement with the current mental health first response system. And so wanted to ensure that we had an opportunity both to hear from the city auditor about their report as well as from BJ Wagner from Meadows about the report that they put together. I think this is a crucial time for this as well. I don't go on in the interest of time, but we've had a string of pretty high-profile deaths of people in mental health crisis in interactions with police over the last few years, from Richard Monroe to David Joseph, Morgan Rankins, Jason Roque, and others. Last Wednesday, we had another tragic incident. Maurice Da Silva, apparently in mental health crisis, was also killed in an encounter with APD. And we've since learned that that some of the even most well-trained folks from APD weren't available to be on scene during that incident. And I think it speaks very much to some of the deficiencies within our mental health first response system that were identified both by the auditor and by the Meadows report. And so with that, I wanted to invite the city auditor, and I believe they have some representatives here to speak to their report, followed by BJ Wagner from Meadows, and then hear from some community advocates and folks in the mental health profession as well to talk about that before we consider a resolution. Thank you.
Hi, all. I'm Corey Stokes. I'm the city auditor, but I'm going to turn this over to the manager and the lead on the audit, Patrick Johnson and Cameron LeGrone.
Yeah, and I'm Patrick Johnson, so thank you for inviting us, and I don't want to take any more of your time, so you introduced the audit. Cameron led that audit, and she'll make a brief presentation.
Good afternoon. In September of last year, we released an audit of APD's response to mental health-related incidents. We did this audit due to an increase in mental health-related calls. Since the audit, our understanding is that APD has been addressing these issues we identified, but we have not done formal follow-up work on our recommendations. To evaluate APD's response to these calls, we use the Crisis Intervention Team core elements developed by CIT International as the benchmark of our analysis. The goal of the core elements is to improve the safety of the person in crisis and the officer, and to redirect the person from the judicial system to the healthcare system. At the time of our audit, APD had organized their response to people experiencing mental health-related issues under the CIT International core elements, as shown on the slide. Our audit identified 3 areas for improvement related to APD's training, response, and evaluation of mental health-related incidents. We found at the time of our audit that APD's crisis intervention training for all officers did not include all best practice elements, such as specialized de-escalation topics and direct interactions with the community served. APD reported that some of these elements were included in the initial Cadet Academy training. Additionally, APD did not offer regular refresher trainings to update officer knowledge and skills related to mental health crisis intervention. We found several areas for improvement within APD's response to these calls. At the time of our audit, call takers did not proactively ask if the caller needed mental health assistance or related resources. Also, dispatchers did not assign a mental health officer to a call unless one was requested by the caller or the responding officer. Additionally, limitations in APD systems made it difficult to provide helpful information to the responding officer, like if the person in crisis had a history of mental illness or was known to have weapons in their house. We also found that mental health officers did not always lead on-scene response and were not always available to respond to calls when needed. APD had a partnership with Integral Care's expanded mobile crisis outreach team to assist with call response, but they were also not able to respond to all calls where they were needed. For example, MCOT staff weren't available during the hours of 10 p.m. to 6 a.m. We did a survey of peer cities' crisis intervention programs during our audit. APD and peer cities reported challenges defining mental health-related calls and tracking the call numbers. We also found at the time of our audit that APD did not evaluate all of their responses for areas of improvement, and APD executive management was not receiving routine updates about these types of calls. Our first recommendation for this audit was that the Chief of Police engage with mental health stakeholders to identify solutions that have worked in other communities, evaluate the needs and available resources in our community, and review what solutions could work to benefit people with mental illness in the Austin area. APD reported that the stakeholder group would begin its work in December of 2018. Our second recommendation was that the Chief of Police use the results of that stakeholder process to implement changes to the city's crisis intervention program. APD reported that the stakeholder group would provide quarterly reports starting in 2019. APD recently provided us with a status update on these recommendations, noting that they are working with the Meadows Mental Health Policy Institute to examine their practices and make improvements. They also stated they would begin providing reports in the third quarter of 2019. Thank you.
Are there any questions?
So I know you just mentioned the ability to share information on prior mental health interactions and involvement. Are there HIPAA PHI concerns that you guys have with the sharing of that data?
I believe that there's always some HIPAA concerns, but if people want to voluntarily provide that information, they can.
Thank you.
The MCOT, and Chief Gay, you can correct me if I'm wrong, it's still relatively new within the city, is that correct? Or how many years have we had the MCOT working?
You know what I'm going to do? I'm going to go ahead and invite Lieutenant Dustin Lee, who is over the CIT and was here to answer some of the questions that may come up.
Okay, that's a good question. I don't have the exact year that it started, but it has been within the past, I would say, 4 years that we've started with MCOT, and CEMS Chief nodding over there. Does that sound right, Chief? Okay.
So we've had time to integrate policies and procedures over those 4 years, or is this something we're still getting used to a little bit?
No, sir. That policy's in effect, and the officers out on the street received updates periodically, reminding them of the resources that are available to them. And those come out in the form of training bulletins. So those are posted on our intranet page so that supervisors can review that with their shifts when they conduct briefings, and reminds them of the hours that EMCOT is available and what they should be used for.
Now, we saw as part of the report that there were times, and I believe it was described as often, or it wasn't that unusual, that they weren't available because they were somewhere else at the time. Would you describe the situation of there being a shortage of MCOT availability, and could you use more of it?
We can always use more availability of EMCOT. Our partnership with Integral Care is one of the best I've seen with the providers that we deal with. We have a very good relationship, both with Integral Care and other private institutions such as NAMI and things like that. So our relationship is very good. We have policy in place advising officers when to call for EMCOT, and Integral Care is very good at keeping detailed records on when calls come in and when they have staff and when they can do the best to assist APD in the city. So while we do always need more availability and more staff, I'm sure Integral Care would say they need more staff. Right now, we have a good working relationship, and so hopefully, as we move forward, those positions will become available, and we'll be able to maybe expand to a 24-hour coverage.
And that's, I was just for people's clarification, you might see this on the service and think that this is something available 24 hours a day, or they're on call, but that's not the case, correct?
Correct.
How many hours, do you know how many hours average daily or weekly they are available?
They're only unavailable from 10 p.m. until 6 a.m., I believe, Monday through Friday. I think maybe on the weekends they go from 8 a.m. to 10 p.m.
Okay, so after 10 p.m. they're not available.
Correct. Their EMCOT is not available to respond to the scene if an officer requests them, but MCOT is always available for the referrals. So the officers, if they encounter a situation where they need to refer to MCOT, then they can, and then they follow up within 24 to 48 hours after that.
Okay. Chris, I'll let you decide which step you want to go to next.
Sure, thank you. Thank you so much for your time. Really appreciate it. If B.J. Wagner, Senior Director of Smart Justice and Adult Policy at the Meadows Mental Health Policy Institute, if you would please come up and present for us.
Good evening. Thank you, Commissioner.
Need a light. There you go.
And it's red.
There you go.
Hi. Thank you for the opportunity to let me come and visit a bit about the Meadows report on Austin first responders and mental health calls for service. I'd like to start out by saying our report is not intended to duplicate the auditor's report nor respond to the auditor's report. And it's not intended to meet any of the requirements found in the auditor's report, although you will see that they overlap quite a bit. Since I know that we have limited time, and if you all received this report, you know it's a little over 100 pages long, then I'll start with hitting what I think are the highlights of the report and then go into the recommendations. But if I'm missing any information that you all would like for me to dig into a little deeper, please feel free to stop me and ask me to do so. And I'm glad that you're staying up here. So we started by meeting with the city and getting a group of stakeholders together as kind of our steering group. And then we pulled a big body of data that we wanted to look at because we needed to know several things about how the first responder system interacted with one another here in the city, and that included how Integral Care's systems interacted with police and fire and EMS as well. EMCOT, by the way, has been around since 2011. It was started with a DSRIP funder, and that funding ended. That was some federal funding that ended in 2017. And you'll hear us in the report talk about the importance of sustaining EMCOT since that funding stream is gone. They've been really impressive over their 7 years of work here. There's a table in the report that goes over all of the data that we asked for. But in brief, we asked the police department for all of their calls for the last 3 years. That included any mental health indicators, and that was if the call was dispatched as a mental health call for service, if there was a mental health aspect to that call noted by the officers, or if it ended in a mental health service delivery. We included all of those. We asked EMS for the same thing, and we asked for enough information on those calls so that we could map them throughout the city to see where they were happening as well as when they were happening. And then we wanted to know what types of response to resistance or use of force, if you will, was used during those calls and what some of the outcomes were related to hospitalization. And that information informed a big chunk of what we looked at first. We know that on average, APD has about 10,600 calls for service a year related to mental health calls for service, while EMS averages just a little over 4,000 a year. And that's pretty static across our 3 years of study, which began in 2016. We looked at 16, 17, and 18. The increases in these calls are happening in northwest and southwest Austin, and they're decreasing in central Austin and the downtown districts, although those areas still remain the highest areas for mental health calls for service for both the PD and EMS service. A lot of cities don't look at their EMS service when they're looking at how to help first responders respond to a mental health call for service, but that's a huge gap in your service array if you're excluding your paramedicine providers, because mental health care needs is a medical need as well. And if you're only asking police officers to put a Band-Aid on it, you're going to continue to pour money into a response that is a Band-Aid response. So we always look to see who else is involved. And in this particular case, your first responders, being both EMS and PD, are responding to the same areas over and over again. They're responding to the same addresses, they're responding to the same people, and they're responding frequently to the same addresses and to the same people. So with just a little bit of data analysis, you can quickly determine how your resources are being used and where they're being used. And that's not just a determination to reduce your resource utilization, but it also tells you who needs help. And that's when you can engage your helping partners, your local mental health authority, Integral Care, who's a really great partner, to do those prevention services. And that was something that we noticed in our report is really missing, is prevention services in the first responder arena. You can see that calls for service are increasing across the board, although not in big numbers, that your call service volume is equally distributed across the days of the week, Monday through Sunday. So there's not any particular day of the week that really stands out, which is unusual. Most communities that we look at, there's a couple of days of the week that are higher than others, but it's pretty uniform here. And that your call for service for mental health care needs is heaviest after 4 p.m. and declines after midnight. And as you guys were discussing just a bit earlier, that's usually when your mental health crisis workers are going home and your first responders are left with little help. The majority of crisis call for services do result in emergency detention, and they originate from where the hospitals are. So your police officers are getting called to hospitals to do an emergency detention. So it's far too late in that person's health care game to prevent that hospitalization once they're already there. Areas that experience the highest volume of crisis calls for service include downtown, east, and northeast Austin, and they match between EMS and PD. So before we move to response to resistance, do y'all have any questions about when and where these calls are happening? It's a tricky little button.
It is. No, my question was not as to when and where, but it was more initially who makes the determination that the call is actually a mental health call other than the person that's calling saying, this is what it is.
I'm glad that you asked me that. We discussed that a bit in the response to resistance section as well as the dispatch section of the report because it's such an important piece of that call. And it can happen in many different places. The dispatcher, if she's well-trained, the call taker, who I'm assuming is also the dispatcher, if she's well-trained and she's asking the right questions, then she can inform the officer that it's a mental health call. The caller can do that, and then the officer on scene can also make that determination. So it just, where it gets tagged in that data stream just depends on who was trained and who noticed it first.
Do we have data showing how often that determination is being made and how the determination is being reached?
I'm sure that data is there, but we didn't look at it in that way in this statement, in this piece of work.
Okay. Is that something that can be obtained? From APD, MS, someone?
We can look at that, yes.
We can also give that data. Our folks use emergency medical dispatch. It's a structured triage question system that come to determinants, and then we can match it against the patient care reports to see how the impressions were of the medics when they arrived, see if a psychiatric patient met the psychiatric patient also when they arrived.
There is a section in the report where we discuss what should the call taker say when they answer the phone, or actually I think we put it in our recommendations. And we usually hear, just in common vernacular where 911 is concerned, do you need police, fire, EMS? And we advocate to say, do you need police, fire, EMS, or mental health? And that way the question is asked right up front. And one of those reasons is because sometimes the caller doesn't know that this is somewhere where I can ask for mental health care needs, or even the call taker doesn't know to ask. And the officer is left without that information as he's getting on scene. We saw that in several cases as we looked at response to resistance. And we looked at it across 3 years. And APD, in this body of calls that we looked at, had 32,000 calls. And we pulled everything that could have possibly been a mental health call that existed in the data. And so, again, anything that had a mental health outcome, anything that had a mental health tag to it, anytime that the call was linked with MCOT or EMCOT. So we wanted to cast a broad net. And we ended up with a little over 32,000 calls. And then we reduced that down to levels 1 and 2. And you can see on the top of page 17 how levels are broken down, but 1 and 2 are the most significant response to resistance levels. And APD used level 2 in these 3 years in 0.3% of their cases, or 94 out of 32,000 cases, and in level 1 in less than 1% of those cases. But then through our stakeholder group and our steering committee, we learned that there were several calls that we did not have included in our data. And so they were provided to us. We looked at them through media clips. And just to be frank, as you're reading the media clip and you work in the first responder world, you're reading it going, well, why wasn't this included? You know, why was this call not included in our mental health data? And these calls were never coded as being a mental health call. So the dispatcher didn't know or didn't ask, and the officer arriving on scene never knew that that was a mental health call he was responding to. And even when we include those cases, I believe it was 6. I left my reading glasses in my briefcase in the back of the room. But even though I believe it was 6 cases, the level 1 response to resistance was then 10 cases across 3 years, or 0.03%. So that level is still pretty low, but a low level doesn't mean it's not concerning, which is why you'll find one of our biggest recommendations in the report is to train the dispatchers. We can train police over and over again, but we've got to train those folks that are sending them to those calls to be able to tell them what kind of calls they're going to and to be able to get them the best resources that they can possibly have.
BJ, and I'm really sorry to interrupt, but just in the interest of time, if you can get to the recommendations
Yes.
portions of it, I want us to be able to deliberate a little bit, and if possible, maybe hear from one other person in the
Actually,
audience
that's
that
much
came.
easier for me, too.
Okay,
It's a
great,
lot of
great.
report to try to go through.
Yeah, thank you so much for coming on. I'm sorry to rush you on that.
So we just want to preface the recommendations by saying that through all of the literature that we look at regarding behavioral health care, not just response to behavioral health crisis calls, but behavioral health care and prevention, everything is wrapped around an integrated approach. And that's really what we are trying to recommend here in Austin, is an integrated approach between behavioral health, whole health, and first responder services to ensure that not only is that each call responded to appropriately, but that's the last time that person has to call 911 for mental health care needs. 911 should not be the primary provider of your behavioral health services. So in our first recommendation, we recommend that the Behavioral Health and Criminal Justice Advisory Committee serve as a steering guide for the Chief of Police on behavioral health crisis calls for service. It's a committee that is already formed of stakeholders that are deeply involved in this issue. They meet regularly. They have executive level staff there, so it's not a designee meeting that folks are going to. And we list several things that we believe they should be looking at, which includes how many crisis calls for service the police department is responding to, what the outcome of those calls are, and what activities the police department is undertaking to ensure that their calls to mental health crisis are least likely to result in any kind of use of force or least likely to result in any kind of a stigmatizing force. And like I said, the group is already in existence, and you have most of the major players in behavioral health, whole health, and first responder services there. Second recommendation is that APD should collaborate with NAMI Austin and Integral Care to create an evidence-based and research-informed crisis call identification and management training for all call takers, and should do so immediately. The topic should cover but not be limited to active listening, mental health symptom recognition, communication techniques for people experiencing a mental health crisis, and verbal de-escalation. Each call taker, every one of them at work, should have to take this class and demonstrate competency as a core part of their ongoing duties. And that once the curriculum is adopted, the police department should have everybody trained in no less than 12 months. And we recommended a certain budget amount to go with this item so that they can cover overtime while everybody is in training. The next recommendation is to integrate that dispatch. Have a clinician present on the dispatch floor, because no matter how well trained a call taker is, she's not going to be a clinician. No matter how well trained a police officer is, he's not going to be a social worker. But to have a mental health clinician on the dispatch floor and to use the program that in such a way that she can receive and triage calls to ensure that the best resources are being sent and the most appropriate resources are being sent, and that she can also be a resource to both EMS and PD officers across the city if they have questions about something that they're seeing at a scene that they're on, and that they can provide resource information to those officers and medics while they're in the field. We follow that up by saying all 911 operators should ask all callers, do you need police, fire, EMS, or mental health? And that protocol should be developed to ensure that even when a clinician is not present in the dispatch room, that they still know which resources to send if they do say mental health. We recommend sustaining EMCOT with telehealth expansion. You guys have been discussing how EMCOT workers can't be everywhere that they're needed, and that's because there's more mental health calls than they can possibly get to. But if you use telehealth for those low-risk, low-need mental health calls and use your live EMCOT workers for those calls that have a higher acuity or a higher need, then you immediately expand your service to cover those gaps. You can't hire your way out of this problem. I don't know any city that can afford the number of clinicians they need to co-respond to every single mental health call in your community, but you can use technology to get you there. This would include establishing protocols between APD, EMS, and integral care to ensure that that service is also available to medics, so that when they arrive to a scene that is has a mental health or behavioral health care need in that scene, that they also have access to an EMCOT worker. We recommend that APD to collaborate with the community paramedic program to do outreach and engagement for people who have had emergency detentions that are recently released, or people who have had a lot of behavioral health calls that have not had an opportunity to engage with a clinician. Rather than sending a police officer to knock on somebody's door and ask them, have they taken their medicine today, let a medic or somebody with some better healthcare training do that, and so folks are not then just taking every last pill left in their kitchen cabinet to keep the police from coming back. And then community outreach and collaboration with NAMI. When we looked at response to resistance, the areas that had a higher number of response to resistance on behavioral health calls were also those same areas where people of Hispanic descent are living below the federal poverty level. And without a deeper study, you can only have a correlational cause to that, and the correlational cause could very well be a language gap. And so we recommend that NAMI work with APD to develop Spanish language materials for those neighborhoods and direct how to interact with the police officer if they arrive for a behavioral health emergency, and then conduct some community outreach with NAMI to ensure those materials are passed out. It's quick enough?
And I will say, as we continue, they're pretty big about us getting out of here on time, but I'm going to make a executive decision that they can come after me. We'll go till about 7 minutes after the hour, so that gives us a little bit of time frame there. Okay.
Well, firstly, just want to thank you again so much for coming and presenting your very extensive report on these topics. And again, I just want to go ahead and ask if there's any questions before we get maybe a couple speakers from the audience.
Okay, so a couple of questions for you. First, a question for you / Chief Gay. What's the integration of your program into the department and the buy-in from your officers on the street, and how much have you guys worked on kind of building trust and building both knowledge of but also acceptance of this programming?
Are you referring just the CIT program in general, or?
Yes.
Yeah, it's the mental health program, and as it transitioned into what we call the CIT, or Crisis Intervention Program, has been around as long as I've been an officer here. Just about back 20 years ago or more, we relied on the county to provide those services, as what usually happens. So you had Travis County mental health deputies that would respond when requested, and then we transitioned to the police department taking over that role. So it's, for as long as most officers can remember, we've had a CIT program, and officers embrace that, and we have volunteers. Officers aren't mandated to become a CIT stipend officer. They volunteer to fulfill that role because that's something that they care passionately about. So I think we've got good buy-in from the patrol officers. They look forward to serving in that role and helping the community in that way.
Then my next question, so you're making a lot of data-driven, evidence-based approaches. Chief Gay, what is your capacity at the department to implement evidence-based approaches, data-driven approaches? What kind of infrastructure do you have in place to really do the kind of background data, number crunching, all of that to make sure that this happens?
To be short, I know we're on time, is that, as we've stated before, we always could use more staff. I do think that we have a very small research and planning department, that we are a department that is moving in intelligence-led but also evidence-based policing. So we don't have the full extent of the staff necessary, but we're moving in that direction.
Okay. Then You also mentioned training communication staff. Are you guys using one of the scripting programs for dispatch, call taking and dispatch, where it pops up, they click the buttons, it gives them the next script that they pop up, and so on, so there's not really that much flexibility, or do you have more flexibility in changing those scripts?
I don't have all that information. I do know what you're talking about, and we do have some scripted language, but I think part of the recommendations is for us to look at our response and our protocol, and we are doing that.
Okay. And then my last question, and then I will leave you alone, I promise. So you talked about the Spanish language gap as a language gap and with our Hispanic Latino populations, but have you also thought about the potential that there's cultural gaps there?
Yes, and that's exactly why we said it was correlational at best right now, because, I know you know, Megan, to dig into that and know exactly what that variable is a much deeper study than we did. So we had to base it off of the correlational information that we had at the time. And that indicated a language gap, which I think falls right into the cultural gap as well.
Okay, cool.
All right.
Yeah, so I wanted to ask maybe one final question and hear from a couple folks in the community, because you all came here and I really appreciate that time. So if you could just give us what was the overall number for what you all anticipated would need to be the investment on the part of the city in FY 2020 to implement the recommendations that you put forward?
I would have to look back and tell you what we told the city, but I believe it was just a little over $1 million for every piece of implementation. Because a great deal of that was moving resources from one place to another. So $2.8 million per year to implement everything that's recommended in the report, and so that would amount to about $2 million per year for sustainability after that.
Okay, great. So there was a few folks in the community that I would really like to get a chance to hear from. Well, firstly, Selena from EMS Union. If you wouldn't mind coming up, I believe Mandy Blott from Austin Justice Coalition, and David. I'm sorry, I don't know your last name, but if you wouldn't mind coming up as well. If y'all could just take a moment each. Again, sorry for the time crunch here.
And I apologize for this, of course, because of time, but if you could each take 2 minutes instead of our particular 3 minutes, that'll give us a few minutes to discuss the resolution.
And thank you again, BJ. I really appreciate you.
My name is David.
Make sure, there you go. Make sure you state your name.
My name is David Balch. I just want to make a very, it's still not on.
There you go.
How's that?
All right.
Just want to make some very brief comments. I'm not a behavioral health expert by any means, but I have worked in Health and Human Services for over 30 years. I'm also a father who has a family member who's mentally ill and has dealt with the behavioral health system, and which has involved the police department. You know, there's a concept called complexity theory, and that's 3 types of problem solving: simple, complicated, and complex. A simple problem is you bake a cake, use the same recipe, you can get the same results. Complicated would be you're sending a rocket to the moon. If you can have failures, but once you figure out how to do it, you can do it again. When you're dealing with somebody that has mental health illness, no 2 people are the same. So I really encourage you, the direction you're going is needed, but be thinking about this from a complexity perspective, from a systems perspective. So when I say that, I would encourage you what is being recommended here in terms of improve the training of the 911 call centers. I know I've called them. I've had mixed results when I'm talking to those people. The city fund additional mental health conditions. When I have had to deal with people that were not trained, it was not a good situation. When I dealt with people that were trained, it was a very positive experience that I got. And then the city expands the EMS community health for the follow-up. I think the more we can be proactive, the better. And then I just have 2 final thoughts here. I did not hear, nor when I was looking through the report, that the stakeholders that were talked to were the people that made the calls. Those are the community. I can tell you I have a different perspective when I'm on the side dealing professionally and when I'm dealing as a parent. And I was encouraged, the last thing I just heard here, which I believe when we're talking culture, we're talking race. I don't see in this community, with the history that we have, if we're not talking about race and culture, we got a problem. And I realize it was a good report, but we've got to go to that next step.
Okay, mine timed at 3 minutes, so I'm going to talk really fast and hope for the best. I'm a clinical psychologist and I live in District 1. Last year I had my first experience with APD involuntarily hospitalizing one of my clients, and the experience highlighted many of the problems that would be addressed if you support the proposal that's before you today. My client had called a hotline for legal advice, and during the conversation she acknowledged having had suicidal thoughts at times, but she never told them she was actually thinking of following through on those thoughts. After the call, the hotline operator called 911, and the 911 operator sent the police to my client's home. My client had to wait for some time with 2 regular officers, and it was only when a CIT officer finally arrived that my client realized they were planning on hospitalizing her. She begged them not to do so, explaining over and over again that she didn't actually want to kill herself. In deep distress, my client called me and asked me to speak to the CIT officer. I explained to the officer that there was a misunderstanding, that the client was not only not actively suicidal, but that hospitalizing her would run the risk of making her more suicidal for a number of reasons. Despite the fact that I was a licensed mental health professional with 15 years of experience, I'd been seeing the client twice a week for the past year, and I'd literally seen the client the day before. The officer said they felt a need to follow through because a hotline operator had told them the client was suicidal, so if they didn't hospitalize and the client hurt herself, the officer would be liable. This fear is 100% understandable, but it reflects a lack of training and experience in how to fully assess a person's risk of self-harm. Because the police officer didn't have those skills and was therefore operating from a place of fear and self-protection, they took away my client's freedom, removed them from their support system, and ultimately did more damage than good. Several hours later, I talked with a psychiatrist on staff at the hospital, and within minutes, they agreed that my client did not need to be there. She was released, but not without having been scarred from the experience. As you can see, this experience exemplifies a lot of the problems with our current system, which would be improved through the funding we ask you to support. If all police officers receive CIT training, valuable police... Oh, okay.
A minute to her.
Oh, it's okay. Yeah, I know you have important things to say. All right, I'm almost done. If we had mental health training and staffing at the call center, as well as an adequate number of mental health providers available, a mental health first responder could have assessed my client rather than the police. They could have done a more effective assessment of the client's suicidal risk, and they would have known how to interpret the information I was providing so that a hospitalization would never have been necessary. Please help us address these issues by endorsing the proposal that will be coming before you. Thank you.
Sorry. My name's Selena. I'm president of the EMS union, and I'm primarily here as a resource if y'all have any questions about what it's like for frontline staff. We go to calls all the time that don't come out as site calls, and they end up being site calls. And EMS, we have a really particular viewpoint of what happens. And to this regard, I really strongly endorse the idea of expanding our community health paramedics. There is a strong need for this to be considered a medical issue as opposed to a public safety issue. And if we have a really special relationship working closely with APD, and our association has advocated in the past having units that have one paramedic and one officer assigned together so that they can both cover the expanse of all the response needed for a patient who's in this situation, because there's a lot of things that we can't do. We also do need to make sure that our medics are safe, which helps having officers there, as well as the ability to have emergency detention. But just having a paramedic there really makes it a medical issue, and think about it from that lens as opposed to a policing lens. So I really support strongly increasing community health paramedics as well as advanced providers in our dispatch.
And I would advise, because of time, if we could go to the resolution, and we can talk about that.
Sure. Thank you so much, all of you, for coming. And again, my apologies for the rush and the time. This happens here, sometimes. I so move to pass the recommendation that was included in the backup.
Second. Do we have any discussion or questions before we vote? We are allowed to ask a few questions before we vote on something, but I do only have one question, and that's at the very end of the resolution. It says, require all Austin police officers to undergo mental health training to eliminate the need for a mental health stipend. is that an aspirational goal? There's nothing in here that would say we have to end the stipend, or would you like to expand on that?
Sure, that is, I would say, aspirational on my part. Yes, this was one of the Meadows recommendations, was to remove the mental health stipend. $350,000 a year would potentially come from that, and that was included in the funding that they had for the $2.8 million because they saw that, as we saw last week, that the limitations that the stipend creates on how many folks are able to serve each shift and be available for these calls actually in some ways prohibits the best trained officers from being on the scene. So this does not make a formal recommendation that the mental health stipend be removed, and I hope it doesn't read as that, but it says rather that we should give the extra 40 hours of training that the CIT officers give to all officers, and so that, you know, the best trained officers, if officers are going to be at the scene, are available.
Okay, great. If there are
I just have one question for clarification. Thank you to everyone that came and spoke to this issue. Being that one of the recommendations from the Meadows report is the stakeholder group, and apparently there is still no report from them, is that something that we should be looking at before passing a resolution, or is
Happy to add something as a friendly amendment if you'd like to propose an additional option.
Would that be an amendment to form a stakeholder group?
No, I mean, there is already a stakeholder group,
Okay.
right? And apparently they're meeting on a continuous basis. From my notes, we are expecting a report sometime during the third quarter, right? I guess the question is, do we anticipate that they will be saying anything different than what has already been said in the Meadows report, or are we fine with what's been said today?
Any opinion?
Yeah, I can't say that I can speak intelligently to what we anticipate that coming out as. So, but like I said, I'm happy to include some additional language to encourage them to come back with something as soon as possible.
Well, then I think that we can include that when they do come back, we can revisit this or have it come back to us again when that report is available. So if we want to update or do an additional resolution at that time, do you think we need to add that language too, or no?
I'm fine to add it if there's will in the body, but otherwise I'm fine.
Okay, let's just add a brief item that we'll revisit this again when the stakeholder group issues its recommendations. So, do we need to vote on the amendment first? Or do we need to vote on the resolution? Let's vote on just adding that amendment. We have a proposal. Do we have a second to add that as an amendment?
Second.
Okay, second. All in favor of the amendment? Unanimous. Okay. We already had a movement. We had a motion for the resolution. If it's acceptable to just use that as the motion for the full resolution now, and we have a second. So unless there is any other discussion, all in favor of the resolution? Okay, unanimous in favor. Okay, we will talk online about items coming up in the future. I will say we do plan on having items relating to homelessness and housing and the recent changes. Basically, every month in the foreseeable future, we plan to bring things before you. But we can talk about additional things. Reach me. Do I have a motion to adjourn? And I think we have a second right here. So all in favor? Aye. Unanimous. Thank you so much, guys.
She's the